My name is Jeff Shammy. I'm the president of the Cedars Cancer Foundation, and I will act as your master of ceremonies today to welcome our 2026 visiting professor, the Tall and Gwen Nacos visiting professor in supportive and palliative care. And I'll also invite Dr. Justin Sanders, the Cappy Flanders Chair in Palliative Care and the director of the MUHC Palliative and Supportive Care Division to say a few words. But I just wanted to take a moment and talk a little bit about our mission and how proud we are for philanthropy to thank the Nacos family for this very, very important, vital gift of philanthropy to bring a world-class specialist in supportive and palliative care annually. And to Gwen, you and your family, in your late husband and Tom's honor and memory, the legacy continues. So we're very grateful. This is so important for our education mission. So ladies and gentlemen, you know Cedars' mission. We raise funds for care, research, and education for the full continuum of life. For pediatric hematology oncology, with our relationship at the Montreal Children's and Sarah's Fund, helping kids with cancer up till they're 18. For adult care, and now we've added the Jackie Aze's adolescent and young adult program and services, helping that incredibly vulnerable patient community of 18 to 39-year-olds. Of course, adult care and giving wonderful supportive and palliative care, respect and dignity right through the continuum of life. La grande majorité des patients suivis par des soins de soutien et des soins palliatifs au CUSM sont atteints de cancer. Nous voulons nous assurer qu'ils recevront des soins personnalisés et de grande qualité à chaque étape de leur parcours, du diagnostic jusqu'à la fin de vie. Over the last 10 years, Cedars has invested almost $20 million in supportive and palliative care programs. And talking to Areej yesterday and today, she was asking about how our philanthropic support is so directed to this vital area of supportive and palliative care. In addition, we're committed to raising more than $15 million to build a dedicated whole person cancer center, which will open next year at 5252 de Maisonneuve West. And it'll be the Cedars Whole Person Cancer Care Center under the leadership of Dr. Sanders. It will house clinics of psychosocial oncology, Cedars CanSupport outpatient services, oncology support programs, wellness programs, survivorship, transition services, all under one roof. I'm very grateful to the many folks that are here today that are going to speak. And I just want to take a moment and ask Dr. Justin Sanders, the Cappy Flanders Chair, to come up and introduce our Tom and Gwen Nacos visiting professor. Justin?
Thank you, Jeff. Thank you so much to the foundation. Thanks to the Nacos family. This is an extraordinary opportunity. Everything good? Okay. Oh, we're changing this. So you got my picture. Jeff and I look remarkably alike, I think, in some photos like this. The Institute for Healthcare Improvement in the United States is a leading think tank around healthcare. And over the years, they've defined what's called the quadruple aim of healthcare. Quadruple aim healthcare is to improve patient experience while improving patient outcomes, improving the value of the spending that we have in healthcare systems, while also improving the clinician experience. Because if you do things that are good for patients but bad for clinicians, they don't tend to happen. So we know that palliative care is a quadruple aim innovation in healthcare. It improves patient experience, it improves patient outcomes, it improves the quality of the spending that we do, and it improves clinician outcomes as well. And part of the reason we know that is because of the research from people like Dr. El-Jawahri and her colleagues at Massachusetts General Hospital. Dr. El-Jawahri is an oncologist specializing in the care of patients with hematologic malignancies or blood cancers and those undergoing hematopoietic stem cell transplantation. Her research interests include investigating patient-reported outcomes, developing interventions to enhance patient-centered decision-making, and designing supportive and palliative care interventions to improve the care of patients with hematologic malignancies and their caregivers across the continuum of illness. She's also interested in adapting successful palliative and supportive care interventions to the digital health platform and exploring models of healthcare delivery to improve patients' quality of life and care. What this doesn't say is just how impactful a researcher Dr. El-Jawahri is, and I think you'll see today just what an extraordinary thinker she is, and really how she's advancing our work in this field. I just want to add on a personal note that, so many people, the conception that we're constantly trying to fight, and the conceptions that are being undone by the research by people like Dr. El-Jawahri is that palliative care is just end-of-life care. And I want to tell you a personal story as it relates to patients with blood cancer, which is that a couple weeks ago, I received from my colleagues a picture of a patient that I took care of 10 years ago. And I'll call this patient Jamie, but I remember Jamie when he was 18 years old as a first-year university student across the state in Massachusetts, where I practiced at the time. And he had been recently diagnosed with a sort of indolent, chronic form of leukemia, and was doing pretty well, but came into us in a severe pain crisis that nobody could really understand. And when they took his blood, it didn't look that bad. There was nothing on imaging, but he was suffering in the most profound way. And as his sort of blast crisis or acute complication of his chronic cancer sort of unfolded, the palliative care team and I, as one of its members, was right there with his family the whole time. I remember on 2 occasions over the course of the year that we were deeply involved in his care and symptom management, walking his parents to the intensive care unit with the real possibility that their child, their 18-year-old child, may not survive. Now, I received a picture of Jamie, again, I'll call him, having come back to visit the Cancer Center 10 years later, having finished his PhD at Princeton and heading off to the UK to be a professor. And I think that this is such a powerful story about the impact that it's not just that that we helped him get through this time, but he remembers us, the palliative care team, as such an integral part of his what ended up being approximately 18-month journey through cancer care. And this is the kind of, this is what we want to bring to the cancer patients that we see at this institution and everywhere. And again, it is only with the help of research that you'll hear about today and research that El-Jawahri has led over the years that we're able to sort of forcefully make the case for our inclusion in the care and integration into the care of people's lives with blood cancer. So I'm really excited that you're here. Thank you very much for coming. And maybe I can advance the slide.
Thank you. Good afternoon. Thank you so much for the kind introduction and all of your hospitality. It's really an honor to be here and a privilege to be here with you all. My hope in this talk is to really focus on sort of how can we leverage technology to achieve the objectives that Dr. Sanders talked about? How do we actually make the lived experience of patients with cancer and their families better in every dimension across the continuum of illness, from the time of diagnosis through survivorship, as you heard. And so with that, perfect. So I will start by talking through why we think about digital health interventions. But I would say one of the main aspects of what we've learned in the context of leveraging technology is that we really need to understand how clinician-delivered interventions, supportive care interventions by palliative care clinicians, psychologists, social workers work in improving outcomes to really design really good digital health intervention. Ultimately, the goal is to really take the active components of what we think mechanistically works to improve the outcomes and lived experience of patients with cancer and think about ways to digitize them. We're going to give concepts of this in the palliative care field. So how do we digitize palliative care work? How do we digitize addressing survivorship issues? I'll give you a proof of concept in the context of caregiver work. And for those of you who are a little bit reluctant to think about technology, I will tell you that I don't think technology is going to provide us all the answers here. And there's an opportunity for us to leverage technology to really enhance the supportive care that we provide all patients and families. And what I mean by that is we're not going to replace Dr. Sanders with all AI, digital health, human coaches. And in fact, we know that some patients with cancer may not want to engage with technology at all. And that's perfectly fine. However, if we're able to meet a basic level of needs, supportive care needs through digital interventions that really enhance patients' engagement. I hope I can at least compel you in this talk to see the potential for that to reduce the burden on our healthcare system as a whole, and to leverage Dr. Saunders' expertise, our psycho-oncology expertise, our social work expertise, to really address the needs of patients who really need that human clinician-directed interaction. And then we'll talk about lessons learned and kind of future direction in that work. So first, why digital health? We know that digital literacy is increasing, and digital interventions can guide patients through the complexity of cancer care. Cancer care is more complex than we've ever seen it before. Most patients go through multimodality therapy, surgery, radiation oncology. It's not what it used to be, a few months of therapy. A lot of patients go through years of therapy to achieve a potential for a cure. And what do we do as clinicians once we see these patients? We see these patients and we basically do a cognitive dump of information at them. You're diagnosed with cancer and we tell you, oh, for the next 2 years, this is what we're going to do for you, right? How much of that do we remember after that cognitive dump? 1%, 2%, right? This idea of cognitive overload, we really do, and from a communication perspective, not provide our patients with a lot of opportunity to really process the information we're sending at them. And you can imagine that if you're doing this sort of illness trajectory and you're going through one phase of therapy to the other phase of therapy, that you'd really greatly benefit from having the ability to learn as you go, right? A more patient-centered approach to gaining knowledge and experience about your illness. And this idea of being patient-centered in how we deliver information can really be accomplished a lot through digital health, through a cancer journey, as you can see, and I'll show you. There are a lot of literature from the mental health field and other fields that we can really leverage digital tools to enhance behavior change, to really enhance sense of self-efficacy, patients having more control over their cancer journey, and really enhance self-management. And I'm going to show you some examples of that. And ultimately, this is a way, a healthcare delivery modality is a way to enhance sustainability and adoption of our supportive care interventions. Why do we need to do this? We do not have enough Dr. Sanders in the world. We do not have enough supportive care clinicians in the world to take care of all patients with serious illness. And what I mean by supportive care clinicians is everybody, right? Our psychologists, our social workers, our nurses, our palliative care clinicians, our lifestyle medicine coach, our survivorship clinicians. We simply don't have enough of them. And so we need to figure out a way to address this gap in the workforce and the need of patients. There's also a potential for a hybrid model. So this is not an either or. You don't have to choose digital health or human coach, but you can imagine putting your hands together, and I'll show you examples of that, where you actually can leverage technology to augment human interventions and perhaps reduce the dose of human interventions. So you have a clinician see a patient, for example, a psychologist or a psychiatrist see a patient clinically, talk to them about their illness course and say, hey, I'm going to give you access to this digital tool. Please use it for the next 6 to 8 weeks, and I'll check with you again in 8 weeks, rather than sort of our weekly therapeutic approach. And again, we'll give some examples of that. And ultimately, this is a way for us to disseminate evidence-based supportive care interventions that we know make a difference for patients and family. So our digital health research platform actually spans the illness continuum. We have some that are focused on the acute phase of illness when patients are first diagnosed with cancer. I'm a leukemia transplant doc, so a lot of my work are in the blood cancer space, and I'll show you examples of that. But we also know that patients really struggle in the survivorship phase of their illness. And we have work that's focused on chronic graft versus host disease. This is the major complication after allogeneic stem cell transplant, where the immune system of the donor attacks the patient and the patient body. And so they deal with a lot of complications related to that. We have issues around survivorship and sexual health. We have a caregiver digital health platform that's really focused on supporting the family caregivers of patients going through the cancer experience. I won't have a lot of time to talk about end-of-life care interventions today, but nonetheless, we really do have to, think about the span of the illness continuum when thinking about how do we meet the needs of patients holistically. So let's talk about this idea of digitizing palliative care. For those of you who were there in the morning talk, I talked about how we know from the evidence, we have compelling evidence that integrating specialty palliative care clinicians like Dr. Sanders in the care of patients with cancer improve a wide range of outcomes. It improves patients' quality of life, reduces their psychological distress, improves caregiver outcomes. As I mentioned, the issue is that we don't have enough palliative care clinicians to meet the needs of all patients with serious illness. And as Jeff mentioned earlier, when we're talking about palliative care here, we're really not talking about end-of-life care or hospice care. I am really talking about palliative care as a medical specialty that is focused on providing an extra layer of support for patients, regardless of the intent of therapy, whether we're trying to cure patients or not, but really trying to get patients, like Dr. Sanders' story, to get through a really difficult time in their lives, right? And so we've shown, and others have shown, that palliative care works when you have clinicians like Dr. Sanders seeing these patients and makes them feel better, regardless of where they're going with their journey. So the question we ask is rather simple. Can we digitize the active components of palliative care? What actually happens in that encounter that we can translate to a digital component to improve outcomes? We've done several studies to really understand what's in the syringe, how palliative care actually moves the needle on patient quality of life. And what we've learned is several things. One, that it's all about intensive report building and validating the patient's experience when living with a life-threatening illness. A lot of what palliative care does is symptom management and symptom education. So really educating patients about their symptom trajectory and what to expect, and managing the expectations during the illness course. There's a huge emphasis on adaptive coping. How do you cope with adversity? And then the other piece is really actually supporting the oncology team in providing the best care for these patients. I don't have time to show you all of that data, but I can tell you that at least we've done a lot of what we call mediation mechanistic analysis that shows us that actually the impact of palliative care on depression, post-traumatic stress, in patients, for example, going through stem cell transplant is mediated in part by reduction in symptom burden and change in adaptive coping strategies. So we actually have a very good sense of what are the active components of palliative care that improve outcomes in this population. And so how do we kind of take that information and think about digitizing it? Well, our first proof of concept was in patients with acute leukemia. We know from research that we have done that palliative care improves the quality of life and symptom burden in this patient population. For those of you who are less familiar with patients with acute leukemia, often they are diagnosed abruptly. They're taken immediately to the hospital to start intensive chemotherapy, and they're usually in the hospital for about 4 to 6 weeks for their initial induction chemotherapy. So it's a kind of a life-altering and abrupt, one of my patients describes it as being abducted by this illness from their lives, right? And so we know that there aren't enough specialty palliative care clinicians across institutions to really address the needs of patients with acute leukemia. Often palliative care, as a result, is actually triaged to address the needs of patients with solid tumor oncology or patients near the end of life. So we asked, can we translate the active components of palliative care to a digital health intervention to address the needs of patients with acute leukemia during that initial 4 to 6 week hospitalization? I'll show you some screenshots of Dreamland. So Dreamland is our app, digital app for patients with acute leukemia. And we did a proof of concept study where we took 60 patients who are newly diagnosed acute leukemia. This is really within days of being diagnosed with cancer. And we randomly assigned them to receive this app. It's a self-administered app that they get on an iPad. And we asked them to complete it during that hospital stay. Our palliative care intervention in patients with acute leukemia was a hospital intervention. So it was palliative care clinicians seeing them during the hospital stay. And those that are not getting the app are receiving usual leukemia care. And honestly, the first question we asked is just, is this doable? Can we get these patients who are really sick, who we're bringing into the hospital to be like, oh yeah, sure, I'll engage with an app with you, right? Can we get them to use it? And can we actually move outcomes that matter? Well, what does Dreamland do? Dreamland takes the active components of palliative care and tries to package it in an app and in modules. It provides validation, supportive psychotherapy, and I'll show you some screenshots of Dreamland. It provides patients with education about their illness course and managing expectation during this really hospital stay. And unlike the cognitive overload model, where clinicians talk to patients within the first hour and tell them everything there is about their experience, this is kind of set up in a modular way. So patients learn about their illness course over the 4 to 6 weeks from diagnosis. And there's a lot of focus on active coping and self-care, some of the components that we think were really active in the palliative care interventions. Here are some screenshots of Dreamland. It's set up as sort of a natural journey outside of the hospital environment. What you'll see in a lot of our work, actually based on feedback from patients and families, we started with low budget. So a lot of our earlier apps are very cartoony, and then they become more, as we had more money, we're able to invest a little bit more in graphics and make them a little bit better. The journey in Dreamland is set up in these modular content. So every week, patients engage in a module that's about 20 minutes. It has medical information about their illness course, incorporated with palliative care principles and psychoeducation about how to cope with what's happening at the time. There's a guide who is there, who they get to meet and get to know, and information is conveyed to them in these text boxes with an audio that goes along, so they hear about sort of the program as they go. One of the favorite things that our patients love about the app is really a roadmap, right? Like understanding what's going to happen. So this is a roadmap for the intensive induction hospitalization. Patients can click, oh, I'm at day 14. What happens with that bone marrow biopsy? Day 15 to 20. If I click there, you hear both about what they're expecting physically, but also emotionally during the illness course. Probably the favorite part of the app is actually the testimonial from patients who've gone through this experience. Not surprising to you, if a patient is diagnosed with cancer and they're going through a hospitalization where they think they're going to die, what a better survivor message than hearing a patient who's gone through that same hospitalization telling you, oh gosh, I survived, and here's how I actually not only survived, but thrived as a result of this experience. So these are real patients with acute leukemia who are really sharing how they got through the hospital stay. And then to enhance engagement, we include gamification strategies to really get patients to engage with apps, because apps are only as good as if people use them, right? If people don't use them, if they're one of those apps that you just download, you use for 5 minutes and throw away, you won't get the therapeutic content. So just to give you an example of some of these gamification exercises, we present a coping sort of framework based on cognitive behavioral therapy, where we talk about the connection between thoughts, emotions, physical sensations, behaviors, and then we give patients an exercise to really reinforce that knowledge. That's one example. One of my favorite games is this whack-a-mole game. Maybe it's a little bit too violent for some people, but the idea here is to, whack judgmental thoughts when we talk about mindfulness. So we provide sort of exercises to make this less of a passive learning process. There's diaphragmatic breathing. There's a lot of psycho-oncology principles that are integrated throughout the app. So let's show you the data. What we saw is that basically patients spent approximately about 68 minutes in the app from diagnosis during that first 4 weeks hospitalization. So this is not a long time. It's about an hour total, right? About 50% of patients completed all 4 modules of the study. What was really interesting is that 80% of those who didn't complete were just too sick. They were in the intensive care unit, they were ill. So pretty much everybody who was able to engage was actually able to engage with this app. What's really great, and I know this table is actually very busy, but what this table shows is looking at quality of life, anxiety, depression symptoms using validated scales, comparing Dreamland, which is our app, versus usual care. And you could see that in this proof of concept small study, there were dramatic changes in quality of life and psychological distress favoring the intervention. Just to give you a sense that like 20 different point difference in quality of life is similar to what we see in terms of end of life care trajectory when patients have a rapid decline in their end of life. So we know we're making a big impact in terms of at least the quality of life of this patient population. Again, I like the numbers, but I actually really like to hear the patient's experience. And so I'm going to just share with you a couple of quotes from patients about this. One patient said, this is one of my patients, I don't know how my wife and I could have gotten through this admission without Dreamland. This was the most difficult times of our lives. When I signed up for the study, I never thought this app would be so important to me. I used the meditation exercise every night to fall asleep. Another patient shared, I was reading a lot of wrong information on the internet. I needed to know what to expect. It was helpful to have a credible source of information. I share these to just show that for each patient, they have a different aspect of what they liked about the app. So it's not that everybody liked the meditation, the mindfulness, the exercises. Some patients really want knowledge, and knowledge can really help them cope with really difficult things. And so you can imagine that leveraging digital health allows you an opportunity to actually package a lot of different information, and patients can take what they want from it. So we actually, based on that data that I showed you, received an FDA breakthrough designation for Dreamland as a promising digital therapeutic. Our ultimate goal is actually to be able to prescribe Dreamland for patients going through intensive induction for leukemia. And the reason for that is that it provides a pathway for us for two things. You can imagine if your doctor says to you, hey, I'd love for you to use this Dreamland as a therapeutic during your hospital stay, the chances that patients are going to engage with it goes way high, right? When a clinician says to you, this is going to help you, I want you to use it, you're more likely to use it. We have good patients who really want to do everything they can to improve their own care experience. But the second piece is it allows us a pathway to actually be able to potentially reimburse these services for our patients. So a digital therapeutic pathway, once it's approved by our Center for Medicare and Medicaid, we'll be able to force insurance companies to comply and actually pay for this service. So we are currently doing a registration trial, just like a therapeutic drug trial, across multiple institutions to get Dreamland approved as a digital therapeutic that can be prescribed for patients with acute leukemia. And then most recently, we've done the exact same thing, except now in virtual reality. So you could imagine if you're hospitalized for a very long time during stem cell transplant, another 3 to 4 week hospitalization. What if you have access to put on some goggles, to get an escape from the hospital room, to go to your favorite spot on earth, to just meditate and take a moment and incorporate some of these active components of palliative care in this? And we're pursuing a digital therapeutic pathway for the virtual reality intervention. I'm just going to show you an example of this just to kind of get a sense of what this would look like. So this is actually our BMT VR. There was an avatar that kind of guides patients through the experience. Now we can actually bring real clinicians in the VR experience. So you get to see these clinicians and talk to them. And just to show you some of the environments here. So you get the idea. If you're in a hospital room for 4 weeks and you just can put on goggles and be in one of these places without including any active components of palliative care, I guarantee you your quality of life will be better, right? Because, there's a lot of less control and less ability to just be and be present in a moment. And this is an experience that allows our patients an escape from feeling like prisoners and being abducted by their illness, right? So I'm going to shift gears and talk about addressing survivorship issues with digital health, just to show you another example of how we can apply this technology to help patients and families. I'm going to talk about sexual health, an issue that we never discuss, but it really is prevalent, very prevalent in our cancer survivor population. It's a very common issue affecting our transplant survivors. We know it negatively impacts patients' intimacy, quality of life, relationship satisfaction, and mood. And more importantly, it's also an issue that feels like when patients go through curative therapy, they're hoping to get their life back. They're hoping to get part in a sense of normalcy. And this is a part that actually symbolizes that normalcy. We also know that interventions to address sexual function are lacking in the context of transplant, but honestly in the context of cancer survivorship as a whole. So what did we do? We actually trained transplant clinicians to address sexual health concerns in practice. We showed that and demonstrated that these transplant clinicians can actually address these issues. But we also heard from our transplant clinicians very clear messages. Listen, as a doc, I can easily incorporate basic medical management of sexual health issues. I can address erectile dysfunction. I can address vaginal atrophy. I can address biological issues. What I struggle with is when you push me to my limit and ask me to talk about intimacy. I'm not trained to talk about intimacy, right? And so this is an example of taking sort of this intervention that was clinician delivered and creating a hybrid intervention where we have clinicians that need to address sexual health issues, address the basic biological issues that affect sexual health, which are actually common across all cancer survivors. And then that clinician tells the patient, hey, I'm going to give you this app. It's called Shift. And I want you to engage with it because it's going to help you with your intimacy, and I want you to engage with it with your partner. So Shift is our first sort of digital therapeutic in the sexual health space. It's called Sexual Health and Intimacy Following Transplant. One of my regrets about this is that this should be actually, honestly, disease agnostic. I don't think it needs to focus on transplant. It should be all cancer survivors because the issues are actually fairly similar. You can choose your avatar. You can choose a nice avatar for your partner. People who are not partnered can also use this app. And based on what you choose for you and for your partner, the content of the app is really tailored to that. So for heterosexual couples, for others, it's really kind of tailored. If you put that you're not partnered, the content of the app is tailored towards that experience. I promise I will keep this PG-13. There are nothing here that will be hard to watch, okay? So this is a journey. It's set up as a journey through the home. You start at the garden. The goal is to get to the master bedroom. Kind of makes sense as a theme for sexual health, right? But again, each one of these is a module. It's about 20 minutes long. It provides information, basic information about what's happening. Why am I having issues with my sexual health and intimacy? And also, what can I do about it, right? And it really uses a very comprehensive framework when we think about sexual health problems. It's not only discussing the biological issues, but the psychological issues, the interpersonal issues that happen, and social issues. Again, there's a guide that helps patients kind of learn how to talk about this, right? Patients have a hard time even bringing up this topic to an encounter. And then there's a lot of these exercises, again, that really try to overcome some of the sexual health issues and really give people some really good intimacy exercise that they can apply at their home. There's a lot of medical information, so patients can actually learn about, they can click on a box and learn about vaginal symptoms, what they mean, what they can do about them. And again, keeping it PG-13, there's a lot of content that we call sensate focus exercises that are really focused on building physical intimacy for patients and their partner. So we did a pilot trial of this Shift app. We took 60 autologous and allogeneic stem cell transplant survivors, randomized them to have a clinician deliver an intervention where they address the biological issues affecting sexual health, and then give patients access to this app for about 8 weeks to see if we can actually make a difference. The enhanced usual care group here received just the clinician visit. So what you're going to see in the data is really the effect of the app, because again, everybody got the clinician first visit here. Again, you see high level of completion. About 70% of patients completed all modules. The majority of non-completers, similar to Dreamland, were people who gotten too sick or had relapsed disease, unfortunately. The mean time spent on Shift is 155 minutes, so this is not a long intervention. And this is looking at sexual health domains. Just to orient you, higher scores can indicate here better satisfaction with sex, better interest in sex. The intervention group is in red, the usual care group in blue, and you can see dramatic improvement in global satisfaction and interest in sex. We also saw improvement in quality of life, anxiety, and depression symptoms. So at least from a proof of concept, we can leverage digital health to really address an area of need. And honestly, feedback from patients is really overwhelmingly positive because they also don't want to talk about this with their clinicians nonstop. They'd rather address it in the privacy of their own home, and having an app to do it makes their life a lot easier, right? So we are now conducting a multi-site trial to really show that this is generalizable. This is not something that's just happening at Mass General. You can imagine the sexual health is a culturally latent construct. So we're really focusing on cultural adaptation of this tool to other cultures, specifically to Spanish-speaking patients in Miami who are enrolled in the study. And again, we're pursuing a digital therapeutic pathway for this to get it approved as something that I can prescribe to my patients after their cancer therapy. And we're doing the same thing to translate other clinician-delivered supportive care interventions, for example, for patients with chronic graft versus host disease, to a digital pathway. I'm going to show you Horizons, which is an app that we developed for patients with chronic GVHD, mostly to show you the evolution of this type of work and what it looks like. So you saw our earlier apps. Shift and Dreamland are probably the earliest apps that we've developed. Horizons is set up as a journey for patients living with something called chronic graft versus host disease. Again, that's the immune system from the donor attacking the patient after an allogeneic stem cell transplant. It's one of the most difficult illnesses I've ever seen, to be honest with you, as a clinician. And part of what's really hard about graft versus host disease is that these are patients who have gone through treatment thinking that they're going to get their life back, and they're cured of their cancer, yet they're living with this unrelenting illness afterwards that affects every aspect of their being. And so that mismatch between the expectation of being cured and everybody telling you, oh, you're fine, and you not feeling fine is a really hard thing for patients emotionally and psychologically. So just to show you, Horizons is set up with nicer graphics based on patients' feedback, and it's actually a journey in the chronic GVHD world. And again, it pairs medical information and knowledge about chronic GVHD. A lot of what our patients with chronic GVHD struggle with is like, they have a symptom. Is this age? Is this being a survivor? Is this chronic GVHD? I don't know. So they can actually search in our symptom library and see if their symptoms are related to their illness or not. And then there's a lot of psychological content. In the apps now, we incorporate real clinicians rather than the avatars that you saw, and there's actual video of the clinicians. So they talk to you, get to know them. This is Dr. Bauman, one of our oncologists. So they actually get to know the clinician that is actually delivering the information to them. There's a lot of communication, Q&A, so allow patients and the clinician to talk through the app. And you can imagine with AI, this is going to only get better and better, right? Again, the most powerful piece has been the patient stories. And in Dreamland, we had 1 or 2 patients that were featured. Now we have stories of 9, 10, 11, 12 patients in our recent apps, because everybody can actually follow a journey of a patient that resonates with them. They can choose to look at all of these journeys, but it's really helpful for them to connect with somebody. And so as you kind of finish certain modules, you have access to more videos, and patient information, which kind of, as you go, you're like, I really want to know what happened with Cassie. I really want to know what happened with Clark. These are our patients, grateful patients who I'm just in immense gratitude. These are all actually my patients who have agreed to be featured in this app. Just to show you the power of this is Cassie talking about her experience. These videos are very short, but they're just to the point. So just watch.
I'm in a constant state of both mourning and celebrating. Having any expectations for what my life will look like is sort of out the window. I've learned that it's not about expectations anymore, but it's about appreciating the moment more than it ever has been. I can't believe I got through everything I got through and still am going through, but it didn't destroy me. At some of the lowest points, I thought it would destroy me, but it never did. It showed me how freaking tough I am. Also, I've learned to be more open with my people, the people that make up my community. I think one of the biggest ways I've grown is that I've gotten a lot closer to my friends, my husband, even my in-laws. I feel like letting your community in on what's going on has made all the difference in my life. Being open about cancer and what's going on, when people ask me, I don't really shy away anymore or feel ashamed. I think sick people should be seen in the world, and letting the community in has been really key to getting through all of this for me.
So you can see how powerful these videos can be, right? And it's just the lived experience of our patients that they're. What's really amazing about this video is we have a day in the studio, and we have all of these patients come and we record in the studio. And Cassie had all of her prompts ready on a prompter to do this, and then at the end of the day, she's like, Areej, can I just do something? And I said, sure. She went in there and she recorded this, just completely spontaneous. And so again, it tells you this is something that can really help our patients kind of see and feel heard and understood in the world. So again, these are more screenshots of Horizons. I can't stress enough that we're not only including psychological content and content that promotes coping and supportive care and palliative care content, but really important medical educational content. We don't do a good job of educating patients about chronic GVHD because it can affect every organ, right? So this is an opportunity for patients to kind of explore and learn about their illness a little bit more, which is also helpful. We have physical therapists that are featured in videos in here. Chronic GVHD can affect joints and muscle and fascia, so massage and physical therapy can make a big difference in patients' quality of life. And so they can actually engage in these little videos that can help them and come up with kind of a regimen for exercise. And again, we have these gamification strategies to allow patients to do practical behavioral change theory. So for example, patients can create a schedule for their low energy day. They can create a schedule for their high energy day. Many of our cancer survivors, when they have a really good day, end up spending all of their energy, and then they have a really bad day the day after, right? So, and I see some people nodding, right? Like it's all about prioritization and figuring out, because that leads to this roller coaster ride of high days, good days, bad days, good days, bad days. And so a lot of what behavioral change is focused on is helping patients really prioritize. And also, when you're having a really good day, don't run out of fuel, right? Save some fuel for the next day. And we help practically in helping them make a schedule for these things. I'm going to shift gears one more time and show you how we're supporting caregivers of patients with cancer going through treatment. So again, I focus on transplant, so you're seeing a lot of stuff on transplant, but again, I would argue a lot of these tools can be disease agnostic or can at least be tailored to the experience of patients with various cancers. So we know that caregivers of patients with cancer require support, and I'm talking about informal caregivers, so family, friends of patients going through the illness. I was sharing earlier today that about 75% of the care in the US health system is delivered by informal caregivers. It's not delivered by doctors, it's not delivered by nurses, it's actually delivered by family members in the home, right? And so addressing the needs of caregivers is great on its own, but it's absolutely essential to improve both patient and caregiver outcomes. And caregivers often neglect their own health when they have a sick loved one, right? They're focusing on them. And unfortunately, we don't have enough supportive care clinicians to address the needs of patients with cancer, let alone caregivers. So earlier today, I shared an evidence-based intervention that we developed that's focused, it's called BMT Care, that is leveraging social work psychologists and mental health clinicians to address the needs of caregivers of patients going through stem cell transplant. This is the BMT Care workbook here. It's a 6-session intervention that's, again, clinician delivered. These were clinicians that saw caregivers either over the phone, over video, or in person to kind of address both the practical needs, how to be a good caregiver, but really the emotional and psychological trauma of being a caregiver. And now we've translated BMT Care from a workbook to an app, the Caregiver app. I mentioned earlier this morning, I wish we were a little bit more creative with the name of the app. It would have been nice to call it something other than the Caregiver app, but nonetheless, again, it's set up as a journey. Patients go through modules and it's aligned with the transplant course. So, right. So caregivers early on want to know different things than when the patient leaves the hospital and comes home. So we provide medical information that is aligned with the journey during transplant. This is Dr. Jamie Jacobs. She's one of our psychologists, and she's, again, a featured clinician in the app. She's the one who actually delivered most of the clinician-delivered intervention, and now she's in the app talking to patients and sharing her experience. Some of the gamification strategies that I addressed earlier now look a little bit nicer with nicer graphics, and that is included in this app as well. And then I'll just show you kind of proof of concept what happened here. So we had 125 caregivers of patients with blood cancers going through transplant, and we randomly assigned them to this BMT Care app. So all these caregivers got is just an app. That's it. There's no clinician. They simply got an app, and we asked them to complete these 5 modules over in an iPad over the journey of the transplant for their loved one. And usual care in the transplant world is meeting with a social worker once prior to transplant for both the patient and the caregiver. And the primary outcome was, can we make these caregivers feel better? And yes, we can. And so this is looking at quality of life of the caregiver as well as caregiving burden. Higher scores on the quality of life scale indicate better quality of life. The app is in red, usual care is in blue, and you can see that those curves just completely separate during the transplant course. Caregiving burden, higher scores indicate worse caregiving burden, higher caregiving burden. And again, you can see that the intervention group in red did much better than usual care group. And again, this translated to psychological benefits. So we saw that caregivers of those receiving the app had much lower psychological distress, depression, and post-traumatic stress symptoms during the first 100 days after transplant. So intervening with a caregiver app, a self-administered app, can really make such a dramatic difference in the experience of these caregivers. So again, we're trying to confirm the efficacy now across multiple studies. And I also think this is an opportunity to think about hybrid interventions, because I think one of the biggest issues is that some caregivers may not want to use technology alone and may actually really like to have the human element. But instead of meeting with a psychologist or a mental health clinician or a supportive care clinician weekly, maybe we meet them once every 3 weeks and then use the app in between to really enhance engagement. So what have we learned from this work? We've learned that we need to develop population-specific interventions. And what I mean by that is if I were to give you an app that I say, this is a cancer app, go use it, many of you would not use that app. And the reason why is people want information that's relevant to them. They want information that's relevant to what they go through. So I hope you saw that there were a lot of common themes in how we build these apps. They're actually not, the therapeutic, psychological, palliative care content is very similar. But we focus on the transplant experience, or we focus on the survivorship experience. And if I take one of my apps and change it from being focused on transplant to lung cancer or colorectal cancer, the active palliative care components are going to be the same. But changing those words and matching it to aligning it with the experience of this patient population is clearly important. The second piece that's important is we have to understand how our supportive care clinicians impact care. It's not enough to say, oh, they make people feel better. We need to understand how they make people feel better so we can actually digitize those components. This is beyond the focus of this talk, but it's been really challenging to find the right partner to develop these technologies with. I went initially to our institutional IT department, and they can't do this work. They simply do not have the capacity to leverage what they have. They're really focused on trying to get efficiency in the clinical healthcare system. So there's a whole other talk about how do you find the right IT partner, because you need someone who understands the lived experience of patients with cancer to understand what we're trying to do in this patient population. There's also an important about commercialization. Again, it's not helpful to have these apps and just have them in the app store and nothing happens. We want to change the standard of care. We want to get patients to have access to these apps. Many of you might have heard of the digital divide. We have people who are able to access digital health interventions and others that simply can't. And so we have to think of ways and strategize how we can get these apps to a patient's hand, whether through a digital therapeutic pathway or other ways. And then the other piece is, how do we leverage digital health to enhance adherence? There's no question that leveraging digital health to deliver interventions makes a difference. The primary issue with digital health is people don't use apps over and over again. And so how do you actually enhance engagement in the context of this work? So ultimately, the goal is, again, to reduce the need for in-person interventions or clinician-delivered intervention, not to replace them. This is not going to replace our clinicians. This is not going to replace our supportive care workforce, but it's going to augment our supportive care workforce. It's going to really allow us to be able to reach more, disseminate more, and identify those who have higher level of needs that really could benefit from seeing Dr. Sanders and other. And then again, the sky is the limit, you guys. I showed you very rudimentary digital health apps right now, but you can imagine how many of you use ChatGPT or Claude? Raise of hand, right? I was telling Daphne earlier that getting through my pregnancy, my best friend was ChatGPT. I mean, it's remarkable, but the amount of support that you get through this AI technology, there's a lot of power in there. There's a lot of risks that we have to think about. There's a lot of issues that we have to think about, but you can imagine that you can replicate a lot of the human interaction with an AI tool that provides you with evidence-based information. And we need to expand this to novel populations. Again, the goal is not to just address the needs of stem cell transplant recipients, but really think about sort of our novel populations in cancer as well. And lastly, I'm a believer that it's the hybrid answer that's the answer. It's not one or the other. It's really how do we leverage technology to augment our care system. And with that, thank you so much for listening, and I'm happy to take any questions later on. Thanks so much, Jeff. Thanks. Thank you.
Thank you, Areej, for that very, very inspiring presentation. I'd like to ask our co-director, Anna Burgos of Cedars CanSupport, to come up and take us through some of the programs and services. And then we'll have Diana Bruno say a few words on a patient testimonial, and then we'll open for questions. Anna?
Thank you. Good afternoon, everyone. My name is Anna Burgos, and I have the privilege of serving as co-director of Cedars CanSupport alongside Dr. Virginia Lee, who unfortunately cannot be here today. In my role, I oversee the day-to-day operations that help ensure our programs and services run smoothly and effectively, and most importantly, are delivered with humanity, compassion, and dignity for every person we serve. Today, I'd like to tell you a little bit more about Cedars CanSupport, who we are, and what we do, and how we support patients and families through one of the most challenging times of their lives. So, what is Cedars CanSupport? Founded in 1984 through the vision and determination of cancer survivor Gwen Nacos, who's with us here today, Cedars CanSupport was built on a simple but powerful belief: no one should have to face cancer alone. Having experienced cancer firsthand, Gwen understood that healing involves more than medical treatments. Cedars CanSupport is a free, comprehensive program for individuals facing cancer and for the loved ones who walk beside them. Fully funded by the Cedars Cancer Foundation and managed by the MUHC within its supportive and palliative care division at the Cedars Cancer Centre. We offer a wide range of programs and services designed to improve quality of life through the cancer journey. Sometimes the most meaningful support we can provide is simply being present, listening without judgment, offering kindness, and helping someone feel seen, heard, and supported. At Cedars CanSupport, our volunteers are at the heart of everything we do. Every day, they bring warmth, compassion, companionship to patients and families, making a meaningful difference through even the simplest gestures. Beyond the remarkable support of our volunteers, Cedars CanSupport also offers a variety of free complementary therapies that nurture the body, the mind, and the spirit. We provide yoga, meditation, relaxation programs that help reduce stress and restore a sense of calm. We also offer art therapy, creative writing workshops, music therapy, and pet therapy, recognizing that well-being extends far beyond physical care. Massage therapy is also available, helping to ease tension and provide comfort when it is needed most. Our resource center at the Cedars Cancer Center serves as a hub of information and guidance, where patients and families can access educational materials, learn about reduced parking rates, transportation and information, and connect with programs and services that help them navigate their cancer journey. Our Cedars CanShare support group offers welcoming environment where people living with cancer can share their experience. For those grieving the loss of a loved one, our Healing Step-by-Step Bereavement Walking Group offers a gentle path towards healing through nature, conversation, and community. One of our most valued services is the free wig and head cover program, which helps patients experiencing hair loss regain confidence, dignity, and a sense of normalcy during treatment. Through the Cedars Wilfred Howick Humanitarian Fund and a referral to the MUHC Social Workers Division, we also provide emergency financial assistance for essential needs such as groceries, transportation, medications, and rent, helping to ease the burdens that illness can create. Our Comfort Kit program offers newly diagnosed patients practical and comforting items, along with handwritten messages of encouragement, small gestures that remind them an entire community cares. On the palliative care unit, we are proud to be launching meaningful legacy initiatives. I think there's a few you here today that provide patients with opportunities to preserve their stories, record personal messages, and create lasting memories for the people they love. One of these is the Legacy Heartbeat Bear program, using digital recording technology, a patient's heartbeat, and if desired, personal messages, stories, or words of love can be preserved inside a special keepsake bear. Families For families, these treasured mementos provide a lasting connection through voice, heartbeat, memory, and love. Above all, we want every patient and family member to know that support is always available. Whether emotional, practical, financial, or informational, Cedars CanSupport is always here to help. Before I close, I would like to leave you with this thought. Cancer touches all of us in some way. Whether as patients, family members, friends, colleagues, or community members, we are all connected through our shared human experience. Behind every diagnosis is a person with hopes, dreams, relationships, memories, and a life that extends far beyond their illness. And behind every person facing cancer is a circle of loved ones who care deeply for them. At Cedars CanSupport, we have the privilege of witnessing every day the extraordinary strength of patients and families. We see how a listening ear, a compassionate volunteer, a supportive community, or simply knowing that someone cares can bring comfort, hope, and connection during some of life's most difficult moments. If there is one message I hope you take away today, it is this: no act of kindness is ever too small. A conversation, a gesture of support, a shared moment of understanding, or a commitment to helping others can profoundly impact somebody's journey. Together, we can bring hope where there is fear, hope where there is uncertainty, and connection when it's needed most. Together, we can help ensure that no one faces cancer alone.
Thank you, Anna. Thank you, Anna. And to the Cedars CanSupport volunteers on Hollywood Squares on Zoom, a shout out to you, and to many of you in the house here today. Thank you for all that you do for our patients. Without further ado, ladies and gentlemen, I'd like to invite Diana Bruno, who's a patient, who will come up and take us through her journey. Diana?
Is that okay?
Yeah, I think so. Just a little bit closer here.
Good.
Yeah. Do you want to check the
This?
Yeah. Thank you, Jeff Shami, for inviting me here today. Thank you, Dr. Sanders, Dr. El-Jawahri, and Anna Burgos, and Gwen Nacos sitting in the front row for your efforts and work helping people with cancer. Come along with me as I tell you about my second ride on the cancer carousel. But first,
I want to give you a bit more. Can we hear in the back? Yeah.
all good?
Yeah, better.
Better.
But first, a brief history of cancer in my family. My father died of prostate cancer. His doctor was Dr. Balfour Mount, father of palliative care in Canada. My mother had breast cancer, then endometrial cancer, and she died of lymphoma. My first ride on the cancer carousel was in 2005 for breast cancer. My treatment was the classic trio of slash, poison, and burn, also known as surgery, chemo, and radiation. My second cancer, 19 years later, in 2024, was for diffuse metastatic bone cancer. I'm 2 years into treatment and will be in treatment for the rest of my life. I'm on targeted therapy and hormonal therapy, and now I measure time in 28-day cycles. Both times I followed the saying, when life gives you lemons, make lemonade. I'll continue my story through a centuries-old Japanese art form, haiga, the juxtaposition of text and image, with haiku as text and photography as image. Malcolm, could you show wherever Malcolm is? The first slide?
There we go.
Okay. I'm going to read the haiku in case you can't see it at the back. Lightning pierces a clear blue sky. MRI results. Here's the backstory. For 2 years before the MRI, I had lost 13% of my body weight for no apparent reason. For 5 months before the MRI, I had worsening back pain and gradually lost mobility. When my family doctor gave me the results, I couldn't believe what she was saying. Next slide, please. Fracture line, paralyzed on shifting ground. I couldn't process what my doctor was telling me. I was stunned, like a deer in headlights. It was an out-of-body experience. She then arranged for an appointment with an oncologist 2 days later. I got an instant migraine, headed home, and went straight to bed. Next slide, please. Metastatic cancer, the existential slap of fewer tomorrows. Indeed, when you get that diagnosis, it's a rude awakening. I spent the day after diagnosis figuring out what was really important to me, family and friends, and then figuring out what I wanted to do with the rest of my life. I chose self-actualization, the top level of Maslow's hierarchy of needs. After my first cancer, I pursued photography and became a dictionary writer. This time, I have become a haiku poet and haiga artist. Next slide, please. You look good. The mallard glides serenely on the lake. Below the surface, paddling furiously. I never know how to respond when people tell me I look good. It takes work to look good. What I've done is to exercise agency to put together my own whole person cancer care team. An acupuncturist, cancer nutritionist, massage therapist, and reflexologist. And I rounded that out by an exercise program with 5 different types of exercise. Next slide, please. Yeah. Lured into the standard treatment, Procrustes bed. Well, one size does not fit all. Procrustes, from Greek mythology, forced travelers to fit into an iron bed, either by stretching their bodies or amputating their limbs. There is a power and knowledge imbalance between doctor and patient. On the one hand, I was so grateful to get a diagnosis, so eager to start treatment and get my life back that I fully embraced my oncologist's treatment plan. On the other hand, after several months, I wasn't happy about the symptoms and side effects. So I declined an additional med intended to help my bones. Instead, I chose a science-based bone-building exercise program. Next slide, please. Fog again. Out of nowhere, this lightheadedness. Sudden onset lightheadedness is one of my 2 recurring side effects. The other is sudden fatigue, like a battery that suddenly fully discharges. In both cases, I have to stop whatever I'm doing, lie down and sleep. It's hard to feel helpless and unproductive. Could you skip the next slide and go to the following one? Yes. Smoldering. Off balance. Swallowtail caterpillars devour the parsley. Not a death sentence. Rustling weather vane. The garden needs tending. A life sentence. Smoldering. The prick of a rosebush. My cancer. This is a summary of my story up to now. There is one more haiga, the last slide. Thank you. Star stuff. The drift into serenity. Remembering the light. This is a haiga I wrote as a tribute to a neighbor who died of cancer, a man who was an astronaut and politician. Thank you for being here today and listening to my story. There is so much more I could say, but I've only been given this amount of time.
Thank you, Diana. Thank you, Diana, for that very compelling, inspiring presentation. And from all your friends and family at Cedars, we're with you on this journey. Thank you. Ladies and gentlemen, this brings us to the conclusion of this Cedars CanSupport public lecture. And with our Tom and Gwen Nacos visiting professor, Areej, really a pleasure to welcome you. I want to thank a few people, if I may. Start with Diana, Bruno, you were very moving. Your talk with us today. Yes, it was 7 minutes, but you took us on a journey, and your art and poetry was so impactful. Thank you. To Anna and Virginia, who's not here, but to Anna and the Cedars CanSupport team, Malcolm, Bronwyn, Lauren, and Thomas, our interns. I can't thank you enough for putting this on. Malcolm, we need you for the Hollywood Squares. We're very grateful. To the Cedars Cancer Foundation team, to Evelyn, and to Sarah and Michelle and Angus and our interns, Fiona, Alec, and any others that I've missed. Thank you for helping us. And to all the CanSupport volunteers in the house, we really were very grateful. To the patients here this afternoon, your courage motivates us. To the caregivers, your compassion inspires us. And to the healthcare professionals, the doctors, nurses, allied health, your dedication, your professionalism fuels our desire to do so much more. Merci à tous. And I really want to say to all of you, we're very grateful. We'll keep bringing these to you. Stay tuned for the emails, the public outreach, and we'll stay after and ask any questions. Thank you so much. We'll sign off the Zoom. Thank you so much. So